I just want to thank everyone for coming tonight. For those of you that are tuning in, please, as Jordan said, please use that Q&A. We will get to everybody's questions. We may not get to your questions during the webinar, but we will stay around at the end. And just as a reminder, everyone from NuSmile is uber reachable. There is more help available than you would ever want or need. So please, if you have questions that did not get answers tonight, reach out to us, anyone from NuSmile or Dr. Bynum or myself, and we promise we'll help you. And I will let the amazing and talented Dr. Ann Bynum take it away.
That's me. Tonight we are going to talk about not just mastering intraosseous anesthesia, but this is more of a mashup that Josh and I have put together over the last few months. We sort of mashed together the introduction and the mastering. So while you're watching this, if you've watched one before, you may see some things and be like, I know that, I can tune out. That's fine, but please tune back in because the very next slide may be something you've never seen before. And if we also say something that's over your head, stick around. We're going to say something that's a little bit, vanilla and intermediate for you as well. So let's get things started with our mashup tonight of advanced intraosseous delivery of local anesthetic in pediatric dentistry. I am Ann Bynum. I'm your host tonight. This is how you can reach me. Please reach out to me for anything. I'm happy to help you with using these devices. I'm happy to help you with anything practice management, anything frenectomy, gifts that you need to buy for your team members. Airway, I can do all the things. I went to Florida State, I went to Iowa, I went to San Antonio for peds. I had a great journey, a great education. But what gives me the most credibility to do things like this is that I built my own practice and I've made a crap ton of mistakes along the way. So Josh and I really pour our hearts and souls into just making it a shorter learning curve for y'all. We were one of the first ones to have these devices and be on the struggle bus the longest, and we're just very grateful to NuSmile for putting things together like this to help y'all come alongside and not have to struggle like we did. I am married to a general dentist. I met him in my dental class, and he is Matt Bynum, and we practice in the same building together. And we have 3 kids, Matthew, Luke, and John. Yes, named after biblical names because we were naughty people growing up, and we figured we needed as much Jesus and our children as we could get. Matthew is engaged to Maddie, Luke is engaged to Faith, and John he's a senior at Clemson. He will shortly probably be engaged to Sal. So very happy family, greatest accomplishment of everything that I'm going to show you tonight, in my opinion.
You guys really need your own TV show, by the way. You could totally do it.
Another great accomplishment, Megan Chorowski. She's also a key opinion leader for NuSmile, and she is my partner in my dental practice every day. I get to laugh and be in the trenches with her daily, and we are definitely goats together. She completes me. And we do have a circus. We run a circus just like y'all do every single day. And these are the people in our circus right here, right? We can't use these devices in a vacuum. You're going to learn everything tonight, and then you have to go into your office and you have to be relatable, and you have to be able to coach your team to come alongside you to make these devices work on behalf of your patients. Like Josh said, I run the top spot, which is Tongue, Tie, and Airway Center. That's a whole nother nut to crack right there, but it does bring me tons of joy. Run Holly Tree Pedo, run Bynum Aesthetic Dentistry with my husband, and then I run the top spot Tongue, Tie, and Airway Center. We added on to the building. We're now helping a ton more patients. Josh just had the privilege to come out and see our practice not too long ago, so he knows what I'm talking about.
It's the size of Costco.
Definitely state of the art. And that's a little bit about me.
Hi, everybody. Just super quick about myself. So I'm on the other coast from Dr. Bynum, and I got the pleasure of teaching one of our BioClear courses at her amazing revamped facility, and it is world class. So, and if you get a chance, I would go visit because it is beautiful. So I'm a second generation pediatric dentist. Unlike some of you that had startups, I was a spoiled baby and took over the practice from my father, which is something that I appreciate all of you that started from scratch, like Dr. Bynum. So as Ann said, as educators for NuSmile, we're not one-trick ponies. We won't just help you with with intraosseous anesthesia or, with any of the other space maintainers, we really make ourselves available as part of being the NuSmile family to help all of you. So I teach mostly on restorative. I'm starting to do a little bit more practice management stuff. A couple of years ago, I moved into a new facility, and so moved into not anywhere as close as a large office as Dr. Bynum, but we're not too shabby. And I have a learning center, and then my practice, all that is in together. And so besides dental anesthesia, I really am weird in like accounting and KPIs and metrics and bookkeeping. So if you have questions on that, I am happy to help you. Next slide. And yeah, I am super excited. When we gave this before, I was telling everyone I'm excited to be out at Dr. Bynum's office, but I am super excited that now their location is now going to be my home on the East Coast. So we're doing 2 courses next year. One is the pediatric course, and one is a brand new course on integrating pediatric dentistry and orthodontics and tooth size discrepancies and anterior aesthetics. First time anybody that I know of has put together a course like that. And so I'm super excited to be working with an amazing team out there. So if you're on the East Coast, please come visit us. And that is their beautiful, amazing classroom. And I have classroom envy because I thought my classroom was nice, but they take the cake. And that is my contact information, joshua@pediatricdds.com. Yes, I snagged pediatricdds.com like 25 years ago or something. And so my course registration site is there for BioClear. You can scan that code. And if you have questions, as Ann said, anything pediatric dentist related, if I can help you, I will. And just a couple pictures of my office. This is when we teach courses. So we change over from daily practice of seeing patients to the learning center. So everything is very hands-on. And I'd love to see you guys out either at Dr. Bynum's office in October or any of the courses in my office.
And I just want to say that when we just taught this in October, we were teaching the BioClear course, but I can't tell you how many people that we like sludged off into an operatory because they wanted to see the SOAN or the SleeperOne. So we also, it wasn't a NuSmile course, but it kind of was a NuSmile course. People got to touch it and see it and use it that hadn't been able to in the past. So that was also kind of cool. If you do come to any of Josh's courses, you will have access to the devices as well.
Yeah. And I'm, these devices are at the core of everything that Dr. Bynum and I and her whole team do. So this is how I give anesthesia. And it's been amazing. And I'm super excited about sharing this with all of you guys tonight. So let's take a poll.
Awesome. So we actually have a new question in the poll tonight. We are...
Oh, nice.
We're wanting to see from you as an audience, because I know we have a lot of familiar faces in here or new people. We just want to know how often you guys would like to see us do a mastering intraosseous webinar.
Never. It's not an answer on there, Jordan. That's weird.
That's because
Never again.
y'all are going to have to see that.
That's because no one listens to me.
I think the question is more like, how helpful do you think it would be, like, for us to put these on? Right?
I don't know how to quantify that in a multiple choice question.
I love who answered me on all my patients. Warm my heart.
Over half the people on this webinar are waiting for Santa Claus to roll up with a Spark Capital One card so people can get these. Get the write-off before the end of the year, 100% depreciation. All right, so Jordan, you want to sort of just give a quick recap to everybody who's been kind enough to participate?
Yeah, I'm going to let it looks like a couple more interests, but so how often do people want to see it? It looks pretty split between once every other month and once a quarter, and then a few would like to see it every month. What device do you own? There's only one SleeperOne user in here, but Quite a bit of SOAN users or those who don't own it. More than half do not own it. Who's using these devices exclusively? There's a few using on all their patients, only on patients until a certain age. There's one, and then split between occasionally fall back to traditional syringe and just do not own one. Delivery method preference, a few for cruise, a couple for drive, and a lot of not sure. So would definitely like to go over that tonight. All right, cool.
And
So
Jordan,
that was
one
the first
thing
one.
really quick that we've been talking about, because we really try to bring as much pediatric dentistry knowledge in general to you guys. If there are certain topics, practice management, restorative, things that we can cover for you, please reach out to NuSmile, reach out to Jordan and to Aaron and let them know. Because if Ann and I don't have the answers, we definitely know the people that do. So if there are things that you're struggling in your practice, both in the back or the front, please let them know and we will bring that information to you.
Yeah, Josh, really, really good point. That was something we Josh had brought up and talked about when he actually came down here to Houston this past weekend, and something we would definitely like to do. So if you guys have any feedback on any of that they'd like to see, please reach out to me, give me feedback, and we'll absolutely try to make it happen.
Well, it's Wednesday night and I'm drinking tequila because I could probably give a whole webinar on how to hire and fire people just in the last month. So if you want a
Perfect.
webinar on that, hit me up. All right, let's talk about these things. We're going to mix and match 4 different practice pearls as we go through this webinar tonight. So be on the lookout for those. Josh, this is you, bro.
So, we don't have to spend too much time in this slide. I started with NuSmile. I graduated my residency in 2003, and that was before most of the things that are on here. I will tell you that I use all of these products, literally every single one in my practice. I don't get a discount for them. NuSmile doesn't, because I'm a KWAL, discount things for me. I pay what you guys pay, but I literally use all of these products. So if you need assistance with anything, BioFlex, I know some people have some problems with that because it comes down to prep design or especially permanent molars or zirconia. I've been doing a lot more of those. Cementation. So if you need help or assistance with any of this stuff, and I know NuSmile is always on the lookout and innovation to bring as many things as they can to pediatric dentistry. So if you have questions about any of these products, especially zirconia, I can really help you with in BioFlex. So please reach out to us. And I'm just excited to see what the future brings because I know there's new stuff coming all the time.
So what is intraosseous anesthesia? To me, it's 2 big words clunked together with a lot of vowels and consonants in there. And I really think I missed this lecture in dental school because it really didn't jive for me because I never gave an intraosseous injection, right? Like we were so focused on giving blocks and so focused on how to do an infiltration. And this was never on my radar. And I've asked others and I don't think it was really taught a lot to many in dental school back in the day or now. But really all it means is you are injecting something into bone. That's what these big words mean together. And that's what we're doing. We're bypassing the soft tissue. We're not fumbling around, trying to numb a million different branches of a nerve and hoping we get the right ones. We're now going to inject straight into the bone to go right to the apex of the tooth that we want to anesthetize.
One of the important concepts, especially for those of you that are new, right? So we have a fair amount of docs on here tonight that don't have one of these devices. What I need you to understand is this is not a new concept, okay? In the course this weekend, we talked about integrating these devices in your office, and so many of us get new stuff and we're super excited and we tell parents, hey, I've got this new thing. I actually don't recommend describing that to your parents in your office that, there's this new device to give local anesthesia. It may be new to you, but you need to realize that this concept of intraosseous delivery of local anesthesia, it was in the literature, and this is in the 1900s, like 1905, I believe. And what this doctor, 1906, there we go. So what this doctor is describing is that once you get through the outer soft tissue, once you get through the cortical plate, if you deliver a certain quantity, certain bolus of local anesthetic into that cancellous bone, Anesthesia is immediate and absolute. And when we say anesthesia is immediate and absolute, it is immediate and absolute. Once you fill that containment vessel of the cancellous bone, the tissue, the teeth, the all the structures that we're worried about being anesthetized during a procedure are numb. But the things that are not numb are what we're going to talk about in a little bit, are lips, cheeks, and tongues. So devices may feel new to you, but this concept is absolutely not new. And you can know in your heart of heart the safety profile is this. These devices have been around far longer than we've had them in the United States. So if there are two pieces of technology that I can say have made a massive improvement in my clinical care, the speed in which I deliver care, the ease I deliver care, the specificity I deliver care, number one's going to be digital x-ray, right? I started at the time when you took your little film, you went into the dark room and inhaled all those fun chemicals. And then today it's just standard of care. And I will 100% guarantee you, and because I've seen it since these devices hit the market, that the way that we're going to show you how to deliver anesthesia, local anesthesia, is going to be the standard of care. If you think about your dental offices now, the way, if you look at that standard syringe, that's how they did things at the end of the 19th century, except they didn't have disposable needles. They just sharpened them, right? But everything else is the same. If we were to practice with all the other aspects of dentistry the same we did from the 19th century, we'd probably lose our licenses. So these devices have made the biggest change, I would say even more than digital x-ray. I can tell you the amount of conscious sedation that I'm doing has gone to almost zero. And I have not picked up a standard syringe in my practice besides maybe 3-4 patients in the last, I don't know, year and a half for anybody under 13. And now that I've got all 3 devices that are sold, all my standard syringes are in a box somewhere. I don't even know where they are because I'm not using I couldn't even wrap my head around using a standard syringe now for a patient of any age. So what do they look like? Basically, what you need to understand is the business end, the needle end of these devices are exactly the same. They both work similarly. They both deliver our local anesthetic, our bolus, into the cancellous bone. Yes, there's some minute differences, but the big thing is portable versus non-portable. There's one of you on tonight that has a SleeperOne, just like me. Good job, whoever you are. Thank you. Please email me. We can have SleeperOne parties or something. I love the SleeperOne. I find it's a little less heavy. I like that I can see the light all the way around it. I actually have it wired into my chair, so it's super smooth. I can pick up my SleeperOne as fast as I can pick up a handpiece and put it right back down. The SOAN is portable, and it really is one of those things. Yes, you can carry it from operator to operatory. I really encourage all of you, and I don't, Ann and I don't get any money from, you buying units. We don't get like a 5% kickback. If you're going to, and when you get to the point where this is the type of local anesthesia that how you deliver, you need to buy multiple units. Okay. You don't want to, yes, they're portable, but the last thing I want you to do is have one of your assistants drop these, right? Because they do have a warranty, but not if you drop it from 5 feet up. And yes, they're portable, but you don't want to be moving this back and forth the office. If this becomes part of what you do, you need multiple units either way. So it basically comes down to portable, not portable. But if you are considering SleeperOne, you have questions for me, please let me know.
I also have a SleeperOne, just to comment on that. Yep. We have 4 treatment rooms, and we have the SOANs it lives in a room. So the SOAN lives in treatment room 1, 2, and 3, a SOAN in each room, and treatment 4 is the the SleeperOne. Well, and whatever room I get dinged to, I just go in there and use the device. We have 5 doctors that work in our practice, and none of us care about between these 2 devices either. I thought I would really be swung towards the SOAN because I got it first, but now that we have both devices, they're so easy to use. So let's talk about the benefits that these devices actually provide to the patient. Oh, let's talk about this. I put this article in here about why it's good. So there was an article that was put out in the International Journal of Pediatric Dentistry just this year in May of 2025. This is what it's called. And this is why it is so great for patients. So they did a study, 79 patients, age 6 to 12, and they tested a block and an infiltration, and they used the SleeperOne as the third thing. So they took pain scores on needle insertion, anesthetic delivery, treatment, and post-op. So 4 different times they were using different like standard guideline testing parameters to test discomfort and pain in these patients. And basically what they found is that children in the SleeperOne group reported significantly less pain scores during needle insertion, delivery of the anesthetic, and the treatment. So using the SleeperOne, they didn't use a SOAN in the study, they used the SleeperOne. And what this is saying is in all 3 of these times, poking the needle in, pushing the anesthetic, and doing the treatment, that all the groups had way less discomfort, significantly lower than when giving a block or giving an infiltration. The other thing was that the post-op discomfort decreased significantly as well, especially at the injection site. So like when it was over and they called a check on the patient, the injection site had significantly less discomfort than the site of a block or an infiltration. So that is straight up new, research in our face on our patient population, on kids. And 79 patients is a statistically significant group of participants to do a study on. So really good article. First time we've really talked about it in the webinar tonight. Just really wanted to spotlight that. So again, super big deal, and we should definitely do a snap and a circle on that. So other benefits to the patient, obviously that whole study talked about decreased discomfort, but also this is not comfortable at all, right? The collateral numbness that a patient deals with, chewing of the lip, right? Think about our special friends, our special needs patients. They are super prone to either picking at their lip or scratching it or chewing it and having some, post-op trauma that we can now completely avoid. No longer are we calling patients and parents think their kid has had a, allergic reaction to anesthetic, because this is completely not on the menu anymore. Josh, you just want to talk about that real quick?
I do. As just, I'll mention it as far as practice promotion goes. If there is one aspect of these devices that parents, besides because I'm sure all of you give great injections and, your patients don't have a lot of pain when you do this, but this one for me is kind of the magic bullet to keep parents happy. When I tell them that their child will not have a numb lip or tongue at the end of the procedure, you see their eyes light up. And I will tell you, multiple times a day, I hear stories from parents of, I don't like when I have to go to the dentist. I can't go back to work. I can't chew, they bite themselves. So if you are looking for something to increase the parent satisfaction in your practice, this is the way to do it. And this is also a good time if you're into, self-promotion, where if your team has a post-op forum or something, we can give the parent and give them a little card saying, hey, we'd love to see other, people just like you that come to our practice. This is a great way to do it. But I can tell you in, I think, over a year and a half now, since I've been using the device exclusively, I have not had one numb lip, one numb tongue the entire time. And that's a big deal.
All right, let's talk about the benefits to the dentist, right? If we're used to holding the traditional syringe and you're aspirating that thing, I do 10, 30-minute ops a day, and I've been doing that for 30 years. So let's just talk about the wear and tear on my hand. That is, I just went and had PRP in my left thumb, in my joint in my thumb on Tuesday, because my left hand is already starting to give me trouble. And I do attribute a lot of that to using a traditional syringe. The push and pull of a syringe is a lot of wear and tear on our hands, which is what keeps us in business. Other benefit, it numbs the patient immediately. This is, besides the collateral numbness, no collateral numbness, this to me is the biggest thing, because we lose patients sometimes just because they're sitting in the chair too long. This decreases the amount of time the patient's in the chair, which is a win for the patient, but it also decreases our time with the patient in the chair, which means, more profitability. We can get that chair flipped a lot faster, work in more same-day treatments. And this was a huge paradigm shift, right? Like the thought of setting your syringe down and picking up a forceps or picking up a handpiece with a, football or round burr on it to be able to bust into a pulp. That is so counterintuitive to, being compassionate with patients. So that was a Huge paradigm shift when we first started using these devices. But again, numbing the patient immediately, very compassionate and very, savvy for our dental practices.
You can flip through these and I'll just talk about them. I will tell you without a shadow of a doubt that 9.6 out of 10 of my patients do not feel even the initial stage 1 of the injection. So I never want to tell a parent, they're not going to have any pain or sensation whatsoever. But if you follow the rules, if you follow the basics as far as having the D in the right direction, and I know, Sean, you asked that question, we're going to talk about that tonight. If you just follow some basic, simple rules about fulcruming and positioning, and we'll show you all of that, you can pretty much guarantee without a shadow of a doubt that a very small percentage of your patients are going to not have any sensation at all. We do need to remember that in the cancellous bone, there are nociceptors for pressure. So once in a while, I know I'll see patients squirm a little bit and they're feeling pressure, but they're not feeling pain. And that's an important concept to understand. I do not, at most times, if you're giving the correct volume of local anesthetic and giving that injection in the correct location, you should not need a supplemental lingual or palatal injection. Now, if you don't give enough of a volume or your positioning isn't correct, or maybe it's a super hot infected tooth and you need to go to a different site as a backup, once in a while you may need to give a supplemental, but most times I do not need to give. We talked about the collateral numbness. It just doesn't exist anymore. This whole idea of midlines and only wanting to restore one side and not the other because of a numb lip or tongue, that's gone. Don't even worry about it anymore. Happens to me almost every single day in practice. We'll work on, let's say, S&T. The child is super cooperative and we've got plenty of time. I'll go over and do K&L because as soon as I'm done with the local, they're ready to roll. And let's say if you use an isolite, you put your isolite in first, then give your IO injection and you are ready to roll. So you can add treatment. These devices will pay for themselves very quickly if you schedule correctly. Definitely fewer appointments. When we say immediate action, I actually, one of the first times I was using these devices and the patient came in and I gave a block on one side, did the work, and when they came back for the second time, I had my SOAN and SleeperOne, and I had a mom almost jump out of the chair into our laps because she said, wait, they're not numb yet, because I didn't explain to her there's a difference between a block and giving an IO, and they are immediately numb. We don't have to use topical. We may get it, show that on a slide tonight. I have not used topical in my practice for a long time. And one of the key benefits, not only stress for your patients and the parents, but also for our staffs, more and more, and this is something Anne lectures on extensively all over the planet, is staff management and building a team. And more it is difficult to get good staff people. And if my team is not stressed out at the end of the appointment, that is worth its weight in gold. Okay. And then mentioned already about practice image, practice reputation. I have patients that are referred to me just because of being able to give local anesthesia intraosseously. If you look at that patient there, this is one of my first times when I said, you know what, I'm never going to give local anesthesia any other way. This was an 8-year-old, not uber cooperative. And I gave one intraosseous injection there between O and P, gave a hapocarp of septo 1 to 200,000. As soon as that needle came out, I extracted all 4 teeth without sensation. That child felt nothing. And if you only have this available to work on anterior teeth, it would be worth it. That's not the case. It works all over the place. But that's one of the key watershed moments for me, and know that I'm not going to use a standard syringe. So we're definitely going to rethink our entire aspect of how we give our local anesthetic. And these devices also give you, I'm going to talk about one of these about flexibility in your schedule, because someone, asked about patient flow. Here's the thing. Now you've got options. You can anesthetize and start work right away. You can anesthetize, go do some checks, and then come back. Or if you are adding treatment on, you just can immediately anesthetize the other quadrant and get starting to work. So I know some people, I think, worry about patient flow a little bit and thinking, oh, do I have to, change the way I schedule? No, what it does is it gives you a lot more options as far as how you schedule and your efficiency for recalls. So you can start right away, or you can give your IO injection, go do a check or two, and then come on back. You've got the flexibility.
All right, first pearl to share tonight. This is mine. This is what we use in our practice to onboard new hires, and we use it for our admin team and our clinical team. We do a 30, 60, 90 training checklist, and we have specific team members who train our new hires, and this form follows the new hire, and it just gives great communication to know like how we need to be helped. After every 30 days, the new hire will transfer to a new team member to be trained for the next 30 days. So it just transfers to them to be like, oh, this person totally gets how to take the anesthesia apart or clean the hand pieces, or how to assemble and disassemble the SOAN, right? Like that's a huge one. We don't want these things broken in the first week that we have them. We have to train our team on this. So this is just a great tool to let the new team member know, hey, how they're doing, and then let the person that's training them know how they're doing. And obviously customizing them to your team is super important. But if anybody wants a copy of these, hit me up. I'm happy to send you the PDFs and you can make them your own. So Josh, tell everybody how these devices start to work.
Let's do it. Okay. So there's this cool thing they come with, and they're called instruction manuals. And for those of you that are sitting in the webinar and thinking, I don't know how to use this thing, what's going to happen? There's lots of hand holding. So of course they come with the manuals, and then there's a full onboarding process. So NuSmile will actually do that for you on Zoom and make sure that you and your teams are fully comfortable with these devices before you start using them on patients. But I would advise get the manuals and read through it. You're going to be using these devices to deliver drugs to children. It's probably a good idea to know what all the little buttons mean. There's not a lot to them. It may seem like there's a lot. There's really not, I promise you. And those are always available online. Something to understand is that although all of you, I'm sure, are great clinicians, you do not have the manual dexterity to deliver local anesthetic in the way it really should be delivered, which is drop by drop, right? So even if we're giving a blocker infiltration, if you shotgun the local anesthetic in there, that causes pain, that causes trauma to the soft tissue, and it doesn't allow the best absorption or the most diffuse absorption into the tissues that we really need it to go. And so if someone, I think early on posted, well, I can just put the needle in the bone and give it manually. I would like you to try that and then see, well, I don't want you to do that, but see what happens. Is number one, you're going to press too hard. You're going to deliver too much of a volume. It's going to hurt. And you are going to spread that local anesthetic in that cancellous bone far too in a grade of a cross-sectional area. So this will not work manually. This is one of the problems that people have with the X-tip is they say, well, I can pop through into the bone when I use, when I screw the hole in there and put the little tripline in, but then my patients are sore afterwards and the anesthesia doesn't seem like it's all that profuse. That's a problem. You can't do this manually. So instead, what we have on the next slide is electronic delivery. If you think about if you took a sponge and that sponge was dry and you put liquid on that sponge with a dropper, drop by drop, you're going to allow enough time to allow that sponge to fully absorb that bolus of local anesthetic. A wet sponge is not going to work. And that's what I want you to think about with electronic delivery is these units will keep you safe. They will actually shut off on you if it senses there's too great of a pressure in the cancellous bone or if there's a blockage of the needle. You will not get in trouble with these. They're the only FDA cleared devices that are designed specifically for intraosseous anesthesia. These devices are reading hundreds and hundreds and hundreds of times a minute in order to properly deliver the correct amount and the correct speed and the correct pressure. One of the main reasons why these devices don't hurt, number one is going to be the needle that we'll show you, but number two is because it's constantly reading pressure, it's giving that local anesthetic drop by drop in a computer-controlled manner, and it's allowing that anesthetic to diffuse, but not diffuse too greatly, but at a pressure that doesn't hurt the patient. So diffusion, one of the things I love to talk about. So let's talk about just quickly anatomy, how things work. So on the maxilla, you have a omnidirectional flow of blood. So if you were to give an intraosseous injection, you put that needle, pass it through the bone through the osseous plate, through the cancellous, into the cancellous bone, your anesthetic would diffuse uniformly mesially and distally. Okay? So given the proper depth of needle and the proper bolus amount of local anesthesia, what we see on the upper arch is a equal amount of number of teeth numb. So in general, if you're truly into the cancellous bone, you're going to get 2 teeth distal and 2 teeth mesial. Now that I will see in primary teeth. In permanent teeth, an older patient, because the needles are not super long, they're really designed for that primary mixed dentition. I'll typically see 1 tooth mesial, 1 tooth distal. Sometimes we'll get bonus teeth, but in primary mixed dentition, I have no problem getting 2 teeth numb distally, 2 teeth mesially. Lower arch is slightly different. So on the lower arch, if you're giving it a true, transcortical intraceptal, intraosseous injection, you tend to see 1 tooth anesthetized profoundly distally and 2 teeth mesially. Now, do you get bonus teeth? Yes, absolutely. I will tell you that the profoundness of the local anesthesia will go down the farther you go away from your injection site. But in the general rules are on the upper arch, it's 2 teeth mesial, 2 teeth distal. On the lower arch, it's 1 tooth distal and then a number of teeth mesial. There you go. And those are pretty good rules to follow.
So we like to talk about it as a 3-stage technique. And we call stage 1 is when you're actually inserting the needle into the mucosa. So we call that, or into the papilla right there, just getting that periosseal area numb. And then you take the needle out. In our practice, I like to rinse the patient's mouth out because there's a little dribbly-do there sometimes and it doesn't taste great. And while the assistant is rinsing the mouth out, then I'm repositioning, getting ready to give the intraosseous portion of the injection, which is stage 2. Stage 2 is penetrating through that cortical plate, making positive pressure with bone, and then penetrating through the bone. You're not stepping on the pedal, delivering anesthetic until you're 100% confident that you're in the bone doing that. And that's why stage 3 is so important, because that is the true delivery of the intraosseous anesthetic at that point, and you're stepping back on the pedal. So let's kind of take this in stages, okay? So the first part, we're going to inject into the papilla. This is what the pedal looks like for both devices. And if you just think about the baby pedal there in the middle, that to me looks like a papilla. So that is the pedal that you're going to step on when you're giving stage 1 anesthesia to numb that.
I've never noticed that. You taught me something new. Thank you.
Yes. And also, if you're a size 10 shoe and you're laying your big whopping foot on there and you happen to touch that outer pedal, the device is always going to default to the inner little tiny pedal there. So you don't have to worry about that. And then Josh said somebody mentioned in the chat about the direction of the needle. On these proprietary Effitech needles, there's a letter D for Dental High Tech, the company that developed them. And that D needs to always be facing out. It needs to be facing facially, buccally, whatever you want to call it, facing towards you, because that's telling you that you have the correct orientation of the scalpel blade of that needle as it enters into the tissue for stage 1. It's only critical for stage 1. When you're doing the intraosseous portion, it doesn't matter the direction of that needle. But if you want your patient to be the most comfortable, you want to be able to lay that tip of the needle. You are not pushing or puncturing that needle in. You're literally like laying it against the tissue and letting it just like almost melt into the tissue right there. So the letter D is very important. And I like to, on the SOAN, when you're screwing that needle on, the D may not always be lined up with the lights. So I will always just do a little, and my assistants do this now, do a little back screw on the needle so that the D is lined up with the lights, because that's what I want to see as the dentist. I want to be able, those lights are telling me a lot of the story, and that D is telling me a big part of the story for stage 1 of the injection.
And can you clarify one thing? Because we did have a question about the secret to loading the D with lighting up the dots. And I think they're probably talking about the lights. So is the D always going to be in the same orientation as the lights or no?
No, it's not. That's why I said you gotta like back screw it. You screw it on, and then there's enough play in it, enough threads in it that if you back screw it, the needle's not gonna like fall off. So I always back screw it because what I found when I don't do that, if the D isn't lined up with the lights, then I'm cricking my neck to like see the lights at the same time I'm seeing the D, or I'm asking my assistant, hey, are the lights blinking right now? I want to be able to see everything in the same plane, and that's the way to do it.
So hopefully that answers Sean's question. Is your D is not always going to line up and see the D and the lights at the same time. If you're working like on the lower left-hand side, the D may be facing out, but the lights are facing you.
That's why I back screw it, so the D is always in line with the lights.
Oh, that's me. I'm number one. Okay. So, number one of the main reasons someone wants to know, interested in tips to make kids more comfortable, this is it. If you think about that papillary triangle as a triangle, the goal is to deliver that bolus of local anesthetic just in the papillary triangle in the center of that triangle. And what we're trying to do is make sure that our soft tissue and our periosteum, our bone, is numb. If you take the tip of your needle and you go to enter directly in the middle of the papillary triangle, what happens is as you give that bolus of local anesthetic, you will drift a little bit distally and your fluid will drip a little bit distally. And you run into the problem of possibly touching the PDL of, in this case, number T. So what I want you to think about in that stage one is enter the needle slightly, in this case, mesial or lateral to the midline of the papillary triangle there. So it is one of those things where you want to just split that triangle in the middle, think about it, and then in this case be lateral or mesial too. And there you go. So don't enter right at the midline there of that papillary triangle. It needs to be towards the more mesial portion of that of the papilla there. And Anne made a very good point, and this is the other tip that I have to make it more comfortable is these needles are so sharp, you do not need to put any pressure at all. You're not poking. Thinking about like an IV, you literally just, as Anne mentioned, just put the needle on the tissue and push a little bit. You don't need to go think about how deep your soft tissue is, right? Your gingiva over the attached gingiva over the periosteum is very thin. That's all you need to get to, right? So just lay the needle in, just barely push. Two things will happen. One, you won't over-insert distally, and you won't find yourself poking the periosteum as you're trying to deliver the first aid.
If you lose the patient during this part of the injection, that's what I'm trying to say. The goal is not to lose the patient during this part of the injection. If you lose them here, you are going to really struggle to gain their trust back to give that stage 2 and then start your treatment. So getting this part right is very important. Josh and I have been using these devices for over 2 years now. So, I'm not using topical anymore. Like, to me, that's an extra step. It's gross. It's in their throat. I don't use topical. I feel like I have mastered this and I can go straight in with stage 1 without needing any topical and have success most of the time. So getting that right is very important. This is a little video here of a kid who already looks drugged out, but they're not. So just showing how you're just leaning that needle in. And it's going to flex. You're going to, see it flex. I love watching kids' eyes, right? That they tell the story. This kid doesn't care. And you just want to leave it. People say, how long are you leaving it in? Well, I don't know. Some kids it'll blanch in 5 seconds. Some kids it'll blanch in 10 or 15 seconds. You just need to be have the agency to decide how long you need to leave it in for each patient. So here are a few videos showing stage 1. This is me screwing up, not having the D pointing out. I'm all nervous about the video. Okay, I fixed it before we filmed. And again, you can see that needle flexing right there, but I'm going to leave it in there until I've got that papilla and periosteum numb. Another example. And I step on the pedal before I go into the tissue because I want it to already start exuding some anesthetic. And that's why it probably doesn't taste great, to be honest.
There's one other advantage there, and I think that's an important point that Anne made as far as stepping on the pedal ahead of time. That's also one of our check steps because these units do work wirelessly, and our chairs are so thick of metal and plastic and rubber and everything else that for your SOAN specifically, if your pedal is way under your chair, it may not talk to your SOAN. And I want you to make sure that the thing's communicating before you start poking into soft tissue. So there's a double added benefit of doing exactly what Anne just said.
Yeah, I like to see the light flashing before I've got it under the skin, for sure.
And has it ever happened to you where it wasn't on and then you take it into the mouth?
I haven't I've taken it into the mouth, but not into, I haven't put it into the mucosa yet, but I'm like, dang it, I didn't push the on button, or the pedals 3 feet pushed out of the way because we weren't using it, or the cleaning people came the night before. So yes, having everything in play before you're, buried in a mucosa is a nice thing. All right, so this is the outer part of the pedal here, and we're going to use this for our stage 2 and stage 3. Okay, so stage 2 is getting the needle in, and then on stage 3 we're going to step on the outer part of that pedal. I think we're going to see this here. Yep. So we're going in, we're making positive connection with bone, then we're giving it a little twist. That's a pro tip for you right there. Give it a little twist, helps it get in there, and then a little tug back to make sure it's in. Just showing you the lights right here, the blinking lights. It's telling you how much pressure the device is experiencing at that moment. Here's another example in our office for stage 2, going in, positive pressure with bone. Then we lean on it a little bit more. Then we tug back a little bit, make sure we're in. We weren't in, so we're going to twist. Twist some more, tug back. We like it now. We're ready to go. Step on the pedal and start to deliver. And you can see, I hope you can appreciate, one of the things we always hear is you want more videos. I mean, we're master clinicians, but we're not master iPhone people. That's obvious. But what we want you to appreciate is the different angles, right? When we're doing stage 1, that's a completely different angle and goal with that needle than what we're doing in stage 2 and stage 3. And I think you can appreciate that. And then I just want to I forgot I have the x-ray here too. It's super important that you read your x-rays because you can't inject into bone if there's no bone, right? If there was I don't know, some reason that there wasn't bone here, that wouldn't be the site that we would have chosen to give this injection in. We'd have had to punt and think of some other locations, maybe a tooth further back or a tooth further forward. So this was just today. This was Dr. Nash in our office. He did this today. Kid had an abscess. He's going to take out I and J on this patient. And you can see there's a good chunk of bone between J and 14 right there. So that's studying your x-rays is very critical. We're no longer just studying them for decay and disease. We really have to look at bone quality and content. So I think this is all going to be in one video if I'm not mistaken. No one wants to hear country music, so we'll shut that off. So he's actually doing stage 1 right now. And I think we'll all agree it is harder to give in the posterior. It's a lot easier to give more towards the anterior, but he didn't have a choice. He has to go back this far. He has to go where the bone is. So now he's redirecting. He's making sure he's in some good bone. He was in it and he pulled it out too much. So now he's going back in. Now he's happy with it. A lot of twisting. And you'll see all the doctors that are using these are all videos from our office. They're not all me though. You got to choke up on that thing, man. You got to be up close to it, almost like you would be on the business end of a pen or a pencil. You're going to have way more tactile sense the closer you are to the business end of that device. So that's the SOAN in the wild right there, okay? Pearl number 2. This is a Jeanette McLean Budd pro tip here. If you want to set yourself, reestablish yourself as a really cool new patient person, give out these little magnets, take pictures of your patients, put these in the magnets, and give them to new moms and new dads. It's a really cool, nice, kind thing to do for a new patient. And then the whole inner part of that pops out too and has our logo and stuff on it. All right, the blinking lights. Let's talk about the blinking lights. We're going to talk about the SleeperOne. There's only one of you on here, but it is very important. When there's different colors, the colors are telling a story. The blue tells you that you're using the device in the mode that is created for intraosseous injections. You can also that's lovely. That's a dog. Sorry. The pink, you do not have to get your traditional syringe out if you want to give an infiltration, or if you want to give you got some wild hair to give a block. You can use these devices for that as well. So with the SleeperOne, if it's pink, you're given an intraligamental or a PDL injection, and then orange would be for an infiltration. For the SOAN, lights tell a little bit different story. If it's blue, if you're using it in blue mode, and you can change this on the handle or you can change this on the pedal, but blue stands for bone. That tells you you're giving an intraosseous injection. Just think blue is for bone. Pink or purple, whatever you see when you look at the device. Some people say it looks purple. This is actually if you're going to use the device for an infiltration. Think about if you've got a over-retained D that you need to get out of there. You don't need to be worrying about giving an intraosseous injection. Just use it for infiltration, numb all the tissue around it, and just pick it out with an elevator or whatever, lift it out with a forceps, whatever you feel like you need to do. And then you saw the lights were blinking in some of those videos. When it blinks, when one light is blinking, that's good. That's go for launch. That you don't have a lot of back pressure yet. 2 lights blinking, you're still go for launch. So you don't have a lot of back pressure yet. You start to see 3 lights blinking and it is time to pay attention. You've got too much pressure building up. That means that the bone cannot accept the amount of anesthetic you're delivering, or you're pressed against something. If 4 lights are going and you don't do something to readjust, it's Mayday. And like Josh said earlier, the device is going to shut itself off because it's got a, default safety mechanism in it. So you're not hurting patients and, blowing up the bone. So what causes the device to recognize this type of pressure? The needle is pressed up too much against the bone, right? Like think about a straw in a McDonald's cup. If you have it shoved all the way in and sitting flat against the bottom of the cup and you try to suck out of it, nothing's coming out of it. There's no space between the bottom of the cup and the straw. That can happen in the bone too, right? You've got the needle pressed up way too tight against a piece of bone, and now nothing can come out of it. Or you've picked up a piece of bone along the way in the lumen of the needle, and now no anesthetic can come out the end of it. Could have bent the needle, and now not, like a kink in a garden hose, you can't get anything to come out of it. Or the bone just isn't porous enough to accept the anesthetic at the rate that the device wants to give it. So how are we going to get ourselves out of this? Things that you can try is first thing to do is give the device time to adjust. These are very smart computerized devices. They figure it out a lot of the time, and they'll slow the rate of anesthetic down, and you'll just keep your foot on the pedal and go along. Sometimes if you just back the needle up a little bit and it gets it off of a hard piece of bone, it can allow the anesthetic to flow. Sometimes you need to remove the needle or even reposition it just a little bit. That will help. Replacing the needle. We're just going down the list of things in the order of things I would start with these first things and go down the list is what I'm trying to tell you. Replacing the needle, again, not a big deal. What we don't recommend is taking your foot off the pedal and putting it back on, because every time you do that, it restarts the cadence of the anesthetic, and it always starts off really, really slow and then picks up the cadence. So every time you take your foot on and off, it's slowing down the delivery. We already hear from you how slow these devices work, and if you do that, you're just adding to the slowness of the delivery of the anesthetic.
And can I make one point on something that you touched on, the difference between PDL and intraosseous, okay? Because we get questions all the time. Well, they had a bunch of over-retained teeth. I gave an IO injection. I went to go take out the teeth right away, and the patient still felt it. My general rule of thumb now is if that tooth no longer has a nerve in it, I will only give a PDL. And why is that? So when we talk about immediate onset of anesthetic, that is odontogenic. That is nerve in tooth, right? But you think about when we're giving an infiltration, we give that infiltration and that anesthetic has to diffuse through the plate into the cancellous bone to the nerve. When we're giving intraosseous anesthesia, the local is actually working backwards on depolarizing the nerve, right? So it has to flow from the cancellous bone through the plate out to the tissue. That can take a little bit of time. And if the tissue is hyperinnervated, if that, they've been picking out that loose tooth for a while, the tissue is red and irritated. So what I do now is if there's no nerve left in that tooth and it's an over-retained tooth, let's say, I put it on PDL mode and I just give soft tissue, get really good blanching, out it goes. There's no reason to wait to do IO, just give it in soft tissue and that's it.
All right, great. Josh, let's talk, this is you. Let's talk about local anesthetic.
Oh yeah, I got so excited to talk about, okay. Local anesthetic selection and key points, let's roll. I like to go on tangents. All right, topical. Do you need topical? Most of you are poo-poo babies like I was at the very beginning and thought you needed topical because you were worried about it. I had a restoration redone for the first time in many years, and the worst part about it was the topical that got in the back of my throat. I do not use topical anymore. Some doctors do. If, let's say, the tissue is really infected and they're worried about patient feeling initial stage 1, they may use it. But I personally do not use topical anymore. And do you use topical at all? Nope. Yeah. So you'll find that most of us literally do not use topical. I'll give you one point, that 2x2 cotton around the distal area administration. We should probably put this in one of these webinars. I keep spiffies, which are xylitol wipes, in all of my operatories now. And I don't use them to necessarily clean teeth. It's just they taste good and they don't taste like anesthetic. And if anything, the biggest problem kids have is sometimes these, because of the technique, you may get a little drops of local in the mouth. I like having that as my either to hold the tongue back or just have it ready if the child doesn't like certain tastes. You wipe off the tongue, it's xylitol, it's not going to hurt them, and then everybody's happy. Okay, so topical, it's okay to use, but you don't need it. You really don't. All right, so there are 2 anesthetics that we mostly use in pediatric dentistry, correct? Articaine and lidocaine. You can use either one, right? It's absolutely fine to use 2% lidocaine with epi. Most of us, to say a vast majority of us, are using articaine. There's a couple reasons why we like articaine. Number one is we know the perfusion through tissue is faster. We know that it gets hydrolyzed in the plasma and not the blood. And then that phthalate ring makes things more lipid soluble. So in my practice, I'm using articaine, either the 1 to 100,000 or the 1 to 200,000. Now, let's talk about length of, actually, let's go one more slide because I want to show, do we have the one more when we talk about how long these last? Yeah, I want to bring this slide up. Someone asked how long these last for. Okay, I want to give you just some general rules to make your life easy. Vast majority of the time in my practice, I'm using septicaine with 1 to 200,000 epinephrine. Okay. Septicaine comes in 2 different formulations, or articaine. It's either 1 to 200 or 1 to 100. Vast majority of the time, I'm using 1 to 200. The only time that I'm using 1 to 100,000 really is if it's a very infected hot tooth, or it's a permanent tooth and that nerve is screaming and I need to close down all those vessels and keep that bolus of local as in one area as long as I can, or if I need to extend the time, I'm using 1 to 100,000. So someone had asked about how long these work. This is pretty accurate. So 1 to 200,000 will give you 30 to 45 minutes of working time. 1 to 100,000, it goes up to 45 to 60 minutes. The one patient group where I want you definitely using 1 to 200,000 is for teens, because for teens, we're using a needle that's not very long. And mostly what we're doing is we're injecting into the interseptal bone. And you don't want to have too high of an epi concentration there because your chances of having a little bit of a ischemic event in the soft tissue, it's not 100%, but it's higher. So if you only want to make your life easy, use one local anesthetic, use septo 1 to 200,000. If you are worried that your patient may have some pain after the procedure, give them a couple drops of local at the very end just to extend things out. But those are just general rules. Again, most of the time, I would suggest using 1 to 200,000. And is that what you do in your office and in your, yeah?
Yes. And we're very simple. I don't want it getting all mixed up. I want it I don't want to grab in the thing and be like, all right, I want to make sure we're getting the same thing every single time. All right. This is a question we get all the time. Josh, these are some new slides that I added. So I'm going to kind of.
That's great. This came up this weekend as well. So thank you.
Why is septo only FDA approved for kids age 4 and up? Well, the study that we all hang our hats on, it only enrolled patients age 4 to 79. So you would be asking the same thing with adults. Like, well, gosh, can we use it on patients who are 82 years old? Right? It would go the same way. And it's just that the study that we're all living and dying by, the hill we're all on, this is the age group that the study was done on. No one ever said it's not okay to use it on kids younger than 4 or adults older than age 79. Safety and efficacy of articaine and pulpotomies age 3 to 4. This study is a newer study than that study. This study was done in the International Journal of Pediatric Dentistry in 2020, so just 5 years ago. And the conclusion was that articaine 4%, 1 to 100, is efficient and safe to use to treat children age 3 to 4. I'm not going to break down the study for you, but there is the resource for it if anybody wants to look into it. Again, when they're doing studies like this, no one's like sacrificing their 2.5
2-year-old.
For you to do a study on. So that, just that's the limit sometime of research. Another good reason why we're using Septicaine is eliminated from the body faster than any other local anesthetic is. And that is what we should want for our children, for our own children, right? 90+% of septo is metabolized in the tissue in the blood, like Josh said earlier, not in the liver. We're not worried about this messing with the liver. It's actually, metabolizing itself in the tissues in the blood, which is a lot safer, especially in children. Another question we get, why does it go so slow? It really just feels that way. I promise you it's going to make your dental appointments so much faster. When we're delivering it, you're delivering about 1 mil per minute. The device delivers about 1 mil per minute, but like we said, it'll increase speeds and decrease speeds depending on what type of bone it encounters. But 2 minutes tops to give like the whole carpule. No, we're not giving whole carpules. We're giving, I'm giving a quarter carpule for MOs and DOs. I'm giving a half a carpule for a pulp and a crown, and I'm probably giving 3/4 of a carpule for a hot tooth that I have to get out. That's usually my standard go-to when I'm doing.
And can you repeat that again? Because I think that's a great, those are great numbers to follow, and it may be helpful for people to know that. Would you mind repeating that?
I was just saying, if I'm just doing class 1s and class 2s, I'm usually given about a quarter carpule per quadrant. If I'm going to do a pulp and a crown in that quadrant, I'll give a half a carpule. And if I'm going to work with a hot tooth that's got to come out, I'm going to give 3/4 of a carpule, because that's just an extra quarter carpule that I'm, crossing my fingers. Baby Jesus, please let this tooth get numb, right? Because it's hot.
Yeah, so I 100% agree. And I think that's a very good general rule to follow.
So here is an example. This is Dr. Megan in our practice. I've got this sped up for you, but you're going to watch an entire treatment. She's given stage 1. Again, super important to be looking at your x-rays where you have bones. So she's going a little, superior to the apex there.
Can you see how good her positioning is here? So she has a fulcrum. A lot of the videos we show earlier that we're holding the device farther away so you can see, that is perfect 100% fulcruming and keeping that patient safe and in line.
She's going to bust out a little restorative right here.
Now, the other thing she could have done, she could have left that
Isolate in to start
isolate in. Now with younger children, sometimes, they may get burned out a little bit, having, it in the mouth longer, but great way to keep them from tasting anything. And I don't think I figured this out 3 or 4 months in, is put your isolate in and then give your local and then just start working. You notice that patient did not even react. He didn't react to the injection, didn't react to those extractions, literally not even the pressure. It's that profound of local anesthetic.
So here's what I want you all to appreciate. Don't come at me and say that this is like going to mess with how long your appointments are going to take. That was a 7.5 minute appointment start to finish, from numbing the patient, putting in the isolate, doing operative, and taking out 2 teeth. The other really cool thing about these devices,
Look at that.
It's like some magical thing that makes the sockets not bleed. I mean, that's what the sockets look like. You don't have like some bloody mess when you're done. So kudos to Dr. Megan. Great appointment. Great videos for us to watch. This was Dr. Nash in our practice doing, he's going to take out a premolar. And what I want you to know is you do not need to numb on either side of this tooth, but it was his first time taking out an adult tooth using the device. So for his own, keeping his panties out of a wad, he chose to numb on both sides of the tooth just to make himself feel a little bit better about what he was about to do. So again, you've numbed the patient, mouth prop goes in, elevating. Like, that's the weird thing to me, is like, oh my God, I can like totally come crush you with this elevator and you don't care.
They don't react. It's just the level of profound anesthetic we get is so different than just giving an infiltration.
So here he is. Less than 7 minutes. So pop that kid out of the chair, get your assistant to clean that room, turn that room over. Now you've got a kid out in recall that needs a couple class 2s done. Now you've got an operatory that you can put them in, and we're working in our practice, we're working in probably 5 to 6 ops a day, because we run 3 columns of op every day, and each of us is working in at least 2, I would say, throughout the day, which is a huge benefit to your bottom line, and to your patients, right? They're not having to come back. This is a sad little friend right here. Again, this is awful, yet we all have to do this, but it's so compassionate, right? You're not having to numb the patient and then let the little boy sit up and let him drink a little bit of water and cry and bleed all over his mom, while you're waiting for the numbness to take effect. You do this right away and you get those teeth out. And as much as this sucks for every single person involved, it's a much less time of a suck.
I would suggest explaining to parents, unless you did that at the beginning, that their child is profoundly numb. Because sometimes you go do this and they're used to, another child needing 10 minutes, they may not be so happy with you. So mention that before the appointment starts, and you got it.
Absolutely. Lots of educating on the front end. So it's a mid appointment. Okay.
Okay. I want to thank, I always do, Eric Hans, for pushing me into giving palatal. When he first told me about this, I said, what? I'm going to give palatal? I haven't done that for like 20 years. What, you want my patients run screaming from the office? Guess what? It 100% works. So if you notice the angulation of that needle, now the picture has a needle farther away, but I still give stage 1 horizontal, no problem. Someone even posted, I think on the forum today, on, well, what do they do on the left-hand side? So if you're right-handed, you have 2 options. You can crank the patient's head over, and if you're right-handed, you're going to pull them all the way over to you so you can get direct access, or I have no problem give palatal access, and I would never have thought about doing that a year and a half ago. So you still follow all the rules. Stage 1, manual bone penetration. I actually find that often bone penetration is easier here on the palate. One of the things is you only have 2 roots there instead of multiple roots on the facial aspects. So I find the bone is easier to get through, and you just have to do it. So don't be a baby. If you have tomorrow, if you have a patient in the chair, give it palatally. I promise if you follow the rules, they're going to be absolutely fine. And you've got great access there. This is especially important. Let's say I and J there, that you had a big fistula. If you try to inject around that fistula and that area is already marsupialized, you have poor bone quality there. You may have an issue with getting that patient numb. On the palatal, rarely do we see that there is, a fenestration through the bone with palatal infection. I get palatals all the time, have absolutely no problem with.
That's just a photo showing different axes, different ways to access that lower left that people talk about. That's a great way to get into it right there. Just showing you the different angulations for stage 1 and stage 2. And
I want to make one point here on how Dr. Bond has that needle angulated. Now, he's giving stage 1 almost vertically here, okay? I want you to be careful doing this because it is a little easier if that patient moves or you move to Pokemon the periosteum and you have an unhappy patient. So if you're going to give in this orientation, please make sure that you have that D facing out and you just lay the needle and you're not pushing down. Hopefully everybody understands that. You can still give an injection this way, but there's a reason why that we attempt to give that stage 1 horizontally, and it just has to do with you have less of a chance of touching that periosteum when you give it in a horizontal approach. Now, if you're familiar, if you get experience here, I don't have a problem doing this. I do exactly what Ann does is I step on the pedal ahead of time. I double check that everything's working. I'll lay that needle slowly as I give that stage 1. But this is, I wouldn't recommend doing this orientation as a newbie. Later on, you may want to think about turning their head and giving it horizontally for that stage 1 and then changing orientation. Oh, hypo teeth. I learned so much from my dear friend, Dr. Patrick Ruck, this weekend about hypoplastic teeth. I always took it for granted that intraosseous local anesthesia delivery made things far more predictable for hypo teeth. But then I learned why that was the case. And I lecture on restoring hypoplastic teeth, and I had no idea why these teeth were more sensitive. Do we have a little video to show there?
Yeah, I'll show.
Stage 1, great orientation, straight through, a little rotation if needed. Check our lights. If you have a hypo 6 or another hypoplastic permanent tooth, I would definitely recommend giving a half carp. And if you need to get a rubber dam on, you're really concerned about it, you may want to bump that up to 3/4. But let's talk about why beautiful. I would say with a block, I'm about 50-50 or so, or a local infiltration with a very hypoplastic molar. I treat a lot of these in my practice. And 50-50 is not great when you take a handpiece moving 200,000 times a minute and touch the tooth, because you can have profound soft tissue analgesia, but unfortunately your teeth may not be the same. So this study specifically showed a 93.5 efficacy with hypoplastic molars, and the only 3 failed cases was just due to a lack of available bone in the area. So the question is why do these teeth have an issue? And I never really understood this until this weekend. We go to the next slide there, and it turns out that the pulps of these teeth are actually in this hyperalgesic state all the time. So these teeth always, if you look at these, I don't know if these are SEMs, but if you look at the difference of the pulp horns, basically what we see with hypoplastic teeth is, number one, we know the teeth are more porous, right? So that cold or hot is going to perfuse through the tooth easier. But these teeth are in this constant stage of inflammation. So what does that mean? If a tooth is constantly inflamed, just like we know soft tissue that's inflamed, it's harder to get numb, is you require either a much greater volume of local anesthetic, which there's only so much you can give with a block, or you need to be able to give targeted delivery. And that's what we're giving with intraosseous anesthesia. We are literally giving that injection maybe literally millimeters away from the nerve itself. You need to coalesce as much local as possible to basically bathe that tooth. If you think about the root, you want to bathe that root in local anesthetic in order to get that tooth that's in this hyper state of hypergesia all the time. One of the ways to think about what we do with a traditional block is if I wanted to numb my finger, a standard block would be I would numb at the elbow. The finger's going to get numb, but it may not be as profoundly numb. And I got to numb all this other stuff in the middle. And I've got to give a much higher volume of solution to get that finger numb. Now, if I give local right at my finger, what's going to happen? That entire bolus of local anesthetic has to be less. And it literally is going to bathe my finger in that local anesthetic. I'm going to have a much higher chance of making sure that that tooth and the pulp is numb. And I used to super stress over hypoplastic teeth just because I treat so many of them. And it was a crapshoot. I'd turn up the nitrous and give a buccal infiltration and a block. And even then it was sometimes patients just had to deal with that tooth being sensitive. I was working on it because I ran out of local. I do not have that problem anymore. I can't tell you a time where I have had a hypoplastic tooth that I did not have profound analgesia. But it's not you, it is the tooth and the nerve.
Pearl 3.
Oh, this is one of my favorite. Okay, very quickly. I promise if all of you do this exercise for your practice, it's worth just this being on there tonight, okay? So if we talk about scheduling efficiency, and this is one of the things I like to lecture on, is a 40-minute operative appointment in your practice really 40 minutes? So this is a time study, especially if you have a new provider in your practice. Let's say you have a new associate, and you say, well, I think it's going to take you 40 minutes to place the sinusoidal crown. You don't know, and you're guessing. Plus, you don't know how fast your team can set up that room and turn over that room. So what we do continuously in my office is we have this little time schedule. And so someone who's not doing the operative is just in charge of being the secretary. And we write down what procedure, the time, and then time arrived when topical was given, right there when we use topical, or nitrous when local was started. And this tells us exactly for that procedure, not how much time it took the doctor, but how much time you needed to book. So for every procedure, let's say sealants, you think sealants take your practice 50 minutes. You know what? It could be 50, it could be 60, or maybe 30. And if you multiply that wasted time over a few times a day, it's going to have the opposite effect of what Dr. Bynum was talking about, is adding, 2 to 6 operatives a day. This can add thousands of dollars to your production. Okay. So, and your staff won't rush, you won't rush, because you truly know, hey, this procedure takes me 40 minutes for everything. Let's book it for 40, maybe longer, maybe shorter. So I really encourage everyone to think about doing time studies for all the different procedures and providers in your office.
All right. We asked this in the poll, the difference in drive and cruise mode. It's really simple. Drive is like driving a car, okay? Your foot is on the pedal. It's like your handpiece, right? When your foot is on the pedal of your rheostat for your handpiece, the motor is spinning, the burr is spinning. So drive mode on the SOAN and the SleeperOne⑤ is your foot is in contact with the pedal and anesthetic is flowing. Cruise mode is just like in your car. You push a button and you don't have to think about anything. Your car knows to go that speed. So same thing, cruise on your devices. You're tapping the pedal and it turns the device on to deliver anesthetic. But you've got to remember to tap the pedal to stop the delivery of anesthetic. Because if you don't do that and you just recap the needle and you set it on the counter, while you're doing dentistry, all the anesthetic is pouring into the cap, which is not fun to clean up afterwards. So one thing that does happen with the SOAN, we have we've got 30 employees in our practice. There's a million hands touching these devices all day, every day, and they get switched from cruise to drive and drive to cruise. So all of us as doctors have to be, privy with how to use them in either setting. But you just got to remember when you're in cruise, you tap it to start it, and you got to remember to tap it to shut it back off.
It makes you feel better. I did that twice to Aaron over the weekend. when we were training.
Yeah, it definitely happens.
Okay, super important. Number one, how do we discuss these devices with parents? I alluded to this earlier. I know it's exciting and you want to go in and you just paid for this thing and you get to the point where you love it and you're passionate about it. My suggestion is don't tell parents that it's brand new. You have this new thing to inject their children with drugs, right? Because that's essentially what we're doing, right? We're placing a drug into the child. The way I describe this to parents is when I first started is this is a digital pump. We're using the same anesthetic that we've always used, but the advantage is the device is going to give the local anesthetic so gently and I tend not to use the word slowly because I don't want them to think that, it's taking longer to numb their child. So I like to use the word gently, that it's going to deliver the local anesthetic so gently that most children don't even react. And that I also do not tell them that it works immediately unless I think I'm going to be starting treatment immediately. Okay. So what I don't want you to do is a little bit of smoke and mirrors, but I don't want you to tell a parent, oh, it works immediately. We start right away. And then you go take off for 10 minutes to do recalls. Okay. So kind of game that system a little bit. If you think you're going to stay and start treatment right away, then you can tell them that. But if you got to step out, you don't necessarily need to mention it. NuSmile did a great job with these brochures. Okay. And they didn't just have somebody in marketing write these things. They pulled a bunch of us and we all put our heads together and they put these brochures together. One of the things that you may want to do as well is if you have an internal marketing program in your practice, I'm not great about telling parents this, but if they're happy and I'm showing them something that I invested my time and money in to make their child's life easier, I'll clip our new patient program little card on top of this. And while they're in the operatory, instead of being on their phones updating Facebook and Instacart or whatever, they're looking through the brochure and, oh, look, here is a little referral card about our patient internal referral program that you get XYZ or whatever your program is. You have a finite time to have that parent in your operatory. And, if their child is relaxed, you tell them, hey, everything's great. I'd much rather knock my phone over. I would much rather have them looking at something about your practice than just on their phone, texting their friends or checking in on doing their taxes or something, right? So this is a great way to introduce internal referral codes. One of the other things you can do too is I know in my practice, I have all of my handouts on a QR code on the wall. We stopped giving out paper. So you can make your own. Anne's got a beautiful handout that she did for intraosseous anesthesia. She's got one for sealants. We both like handouts for parents to read, but instead of doing paper, you can have a QR code in your office, have it on the wall, have parents scan, and they can download that. Using terms like it's a magic wand or taking your tooth temperature. Sometimes if I have a little one who's struggling a bit, I'll have them, okay, listen, we're going to listen for the beeps and your tooth is falling asleep. So whatever your shtick is, I think describing parents as, this is a wonderful method of giving anesthesia more passionately or more controlled manner. And guess what, mom, dad, parent, grandparent, whomever, your child's not going to have a numb lip and tongue afterwards. And as long as you're not doing extractions or something, I tell them, go do whatever, go have lunch. It's really nice for those patients before lunchtime too, to tell them, yeah, you can go ahead and go eat. Be a little careful with your teeth, but your lip and tongue are not numb. So make this a dual purpose. Get your internal referrals and make all your patients happy. Oh, and here you go. So yes, this is, Anne, you want to talk about this?
But just we have these, Larry started this and I sort of massaged it to make it more customized to my practice. But this hangs on all the windows. Parents don't come in for ops in my practice. They can stand at the window and watch and lament there. But this hangs on all the windows so they can see why. We have a culture of why in our practice. Like, why do we need an X-ray? Why are we using this? Why are we doing everything we're doing? And we want to pull our parents into that same culture.
Yeah, and I like this. It's simple. It's easy to understand. And again, if you have this as a handout, like if you don't have parents in the operatory, you can put this as a handout with your with your internal marketing information attached to it.
Mm-hmm. So we're gonna cut to some of the things that we've read about on the Facebook groups. And one of the things is, why is the patient experiencing discomfort? They're not numb as long, right? So it may be that they've waited for a sibling to finish treatment before they're checking out, and now the numbness is going away, and you just did 2 pulps and crowns next to each other, and the crowns are tight, and now the kid's a little whiny tail because the numbness is wearing off, right? We're not numbing kids as long anymore with these devices. And they're starting to feel that treatment discomfort just a little bit sooner. And your brain's going to go straight to, oh my God, it's the newest thing. It's the thing I'm doing different. That's why my patient's hurting. And it's probably not the case. You're probably in your feels in your head about it. The other thing is, at the beginning of this, when you're learning it, yeah, you're going to be stabbing your patient a few more times. You're going to be twisting and turning and pushing and pulling and in and out and on and off the pedal. It's not going to come to you naturally at the beginning. That's why we want you to practice on your husband or your wife, or on your dental assistants that are highly paid, or on a patient that's under IV sedation. Those are actually really good patients to practice on, to get your technique down and shorten your learning curve. But the more times you're going in and out and doing all this stuff, yeah, you can have a patient that's got a little bit of discomfort. And then the other thing would be over-delivery. Over-delivery in stage 1 can cause ischemic tissue. And that's another reason, like Josh mentioned, we really want you to stick with the 1 to 200,000, which has a lesser dilution to it, so that you don't cause tissue like this. So Dr. Nash, wanted to get numbed up yesterday with one of these devices. And today we looked at his tissue, and it looked like this around the premolar that got numbed up. But he didn't even know it. He didn't even know that the tissue was sore and irritated. So sometimes, even when you're not delivering a high volume of anesthetic, the tissue will respond like this. But, this isn't a kid writhing on the floor based on what we see here, and when it presents like this, and we get all in our heads like, oh my God, I've done something so horrible here. It may just happen sometimes, even when you're doing everything right, but it's usually when you're causing some sort of an over delivery situation. Another reason it hurts is you're in the PDL. Injecting into that space and creating a capsule of anesthetic, that didn't feel great. So, knowing your anatomy, making sure you're in the right plane, that your needle's in the right plane, is extremely important.
I want to touch on 2 quick things that Dr. Bynum mentioned. Number one, and this actually gets to one of the doctors asked a question about, does age make a difference, like older children, permanent teeth? I tried on teenagers, and I'm sure in bone. I will not guarantee you that you can pop through with manual bone penetration on a teenager or an adult. This weekend when we did training, I did some myself, and some I helped out, and I found that most adults, if they have thicker plates, you're not going to pop through. So these devices ideally are designed for primary and mixed dentition. In my hands, I typically will find at 13 or below, I can usually penetrate through bone, as long as they're not like a big football player, 300-pound kiddo in my practice. But most patients I find 13 and under, I can get through. But for your 15, 16-year-olds, don't be dismayed if you can't penetrate through that cortical plate. It may be that this is not the right device and you need to do something different. If you can penetrate, just know that you may only get 2 teeth numb, 1 tooth mesial and 1 tooth distal. So these are the 4 P's, my mantra that I say to myself literally every time before I give an injection. So number 1 is always, you want to advance there for me, Dr. Ann? Is always power. Dr. Ann is smarter than I am, and I have had multiple times where I have gone to give stage 1 and looked and said, this thing's not on. And it is virtually impossible to turn it on and not overinsert the needle all at the same time. So I will pick it up and I will look and make sure that power is on. Just know for your SleeperOne, now that's going to stay on all the time, but for your SOAN, it's defaulted to power down at 10 minutes, and that will give you 30 full carps of delivery. But at 10 minutes, it's going to shut off on you. So when you go to pick it up, either yourself or your team, go ahead and make sure that unit is on, okay? Please don't store your your SOAN upright in the power base with a compule or cartridge of local anesthesia in there. If for some reason there was a problem with that carpule and it leaked, I don't want it to go down into the unit itself. So once it's loaded, needles on, it needs to be just on the countertop. Then number 2 is my plan. Review your radiographs. Every single time, Dr. Bynum mentioned this multiple times. I need you to make sure that you're injecting into an area that has organized bone. If you have an abscess between A and B and there's a big area of elucency there, you can inject all day into that area, but you may not get profound local anesthesia. You may need to think about picking a site that is more mesial or distal or palatal, so where you need to get profound local anesthesia. So I'm going to check my radiograph. I'm going to make sure my site is good. I'm going to review, tell, show, do, all the things that we normally do. Then number 3 is the pedal. Is the pedal in the right location? I don't want you to give stage 1 and realize, or try to give stage 1, try to do your papillary injection and realize the pedal is in the other room when the assistant brought it over for your associate to use. So is the pedal there and is in the correct location? I love that Dr. Ian mentioned that she clicks the pedal right before she gives stage 1. I do the same thing, just make sure it's talking. And then position-wise, is the patient in the right position? Is my foot in the right position? And am I in the right position? So power, plan, pedal, and position.
Pearl number 4, this is my pearl. These are the containers that we bought off of Amazon to store our needles, the container that holds the carpule of anesthetic and the anesthetic. So these sit right on the counter, because if I bend a needle or break a needle, I don't want to be fishing around in a drawer and our assistant fishing around in a drawer. I want it right there available to me to get another one out. So here's the QR code if you want to find the link to Amazon to order these. They're great. We have them in all the treatment rooms. So what are some key tips to help me make the switch to electronic anesthesia? It's going to make you more money. I'm promising you that. If you're looking for things that are profitable, don't look at it as a liability to lay out the money. Look at it as an asset and what it's going to do for your practice,
100%.
patients, and the reputation of your practice. Please, Lord, tell me, Erin, that I have the right prices up here.
Yes, you do.
Okay. Woo. Okay. Making sure that, because I know there's talk about the prices going up in 2026. So, if you want Santa to bring you these, this would probably be the time to be thinking about doing that. I don't know if there's going to be any sales for Black Friday. We're not privy to any of that, but these are pretty good prices right here. And the more you buy, the price goes down. And then there's the prices of the needles as well. So I just encourage you to get out your credit card and swipe it and get some of these. You can, figure out how to pay for them later by putting them on plastic. And I just encourage you when you're training is to be patient. I'm not a very patient person. That was probably the biggest demise that I faced in doing all this, is I'm not patient. I wanted to pull out the traditional syringe when it wasn't going according to plan, right? I didn't have webinars to watch, and I just had to fake it till I made it. And when I couldn't get it in the bone, or when I was busting up needles, I just wanted to pull out the syringe. And I would just tell you to please be more patient than I was, and to just keep practicing, right? Practice on, I'm not joking, practice on your assistant, practice on a family member. IV cases are great. Kids who are well behaved are great. Don't go for a behavior management patient as your first patient. Don't go for a 14-year-old that's playing on the varsity football team. Let's read the room here before we're using these devices so that we can get our confidence up. Join the Facebook group, right, Josh?
100%. There is so much help out there. Nobody is mean on there. I don't think I've ever seen anybody mean, but if they are, they get kicked out immediately. But you're going to want advice here. And people literally, some of us are fighting to see who can ever, respond the fastest, because we're all here to help. And that was done for us.
And then lots of training available to you. NuSmile is not just selling these devices and saying meh, figure it out.
Good luck to you.
Yes, lots of great opportunities. They have standalone courses. They have courses hooked on to Restore courses. If you have a big enough group, they will send somebody out to help to help train the group. So just, know that you can get your hands on these things a lot of different ways. And these are just some of the ways. We've gone to residency programs. We've gone to study clubs. We've gone to full conferences, bourbon and baby teeth, just lots of places that you can try them out. Lots of ways to try it out. All right. And this slide here says, so what are some final pointers that we can give to everyone? When you know the solution to all your problems and you just don't want to do them. I'm telling you, this is going to solve a lot of your problems. I have a lot of stubborn ass friends who did not want to get these devices in the early stages. They did not want to be early adopters. And now there's some of the people that come up to me when they see me at meetings or, when we're talking and they're like, oh my God, why didn't I get this sooner? I don't think I've ever had one person say to me, you led me down the wrong path. I wish I'd have waited longer to get this. This sucks. Like, nobody says that. Once you get it in your hands and you get comfortable using it, this is going to solve so many of your problems in your practice. It's going to decrease your anxiety, your patient's anxiety. You just, get over yourself with what it costs. Like, we've all spent way more money on dumber crap that we don't use. This is something you're going to spend the money on and you're going to use.
Right.
And just
can I make one quick point?
Yes.
I'm glad you showed those studies at the beginning, because now that we have international published studies showing that the pain is statistically less with these devices, I hate to say it, but I almost think it is getting the point where it's unexcusable not to use them. If you have the power to introduce something in your practice and know that your patients are not going to have the same level of pain delivering local, I think it just needs to be the standard of care without overthinking.
Yeah. So again, don't overthink it. I mean, we all had to just think we were dental students and we had to learn how to give infiltrations, blocks, SNAs, mentals, whatever all the heck we were doing. And we didn't have time to overthink it, right? We just had to do it because we were being graded on it to go to the next grade. So this is just, we're great at what we do now. We know how to read a room. We know our patients. We know behavior management. We know anatomy. This is just going to come second nature. The learning curve will be a lot shorter than everything that we learned in dental school. And we're not reinventing the wheel here. There are plenty of people now. It's been around for 2.5 years. Plenty of people you can reach out to see the devices, get help with these things. So don't just sit there and think you got to suffer in silence in your practice if you buy it and you struggle with it. We all want to help you get better.
Make a video. People will say, I need help, and send us a 7-paragraph dissertation on the problems they're having. And then when I've asked them to send a video, what we see and what they're writing are two totally separate things. Get parent permission. What I would suggest doing is when you first start, leave the phone in your operatory or stick it in your pocket. And if you're having an issue, just take it out, ask the parent to, permission, take a video, and then just, I'm having problems, send it to us. And that's all you need to do. You send it to Aaron, or send it to Jordan. They'll get it out to one of us and we will help you. But seeing the real deal live is going to be what we need to do.
When you're getting consent from the parent, don't tell them you're having problems.
Yeah, don't do that.
I'm killing myself here. All right. So again, why do you need these? Immediate action, predictable anesthetic, especially on those hypoplastic 6s, no delay in anesthetic delivery and ability to treat, way less stressful for everybody, no post-op side effects, optimize your appointment time, which increases your profit margin. And this also increases the reputation that you have in your practice. I can't think of any other better reasons to get these devices. Oh, yes, I can. Christmas is coming. So hurry up and get them. And if my kid, who was a D1 at the time, could get his brother numb with it, I'm pretty sure everybody else on this call can. He's a D3 now, and he thinks it's total BS that he has to use a traditional syringe in dental school now, because he's used this device now in our practice. He's brought some of his classmates to our office to use it. And I'm super excited that this is going to be the standard of care for him when he gets out and starts to practice in the next 1.5 years. These are all the people available to help you. There's more than this, but this is just a start. All these people want to help you get better using these devices. Josh, you want to talk about the next course coming up?
Oh, yeah. 25 sold out. So Nashville, super cool. Who's teaching this one? Do we know?
Not I, said the fly.
I don't know. I'll find out while you
I will tell you that, I lecture professionally, and I will tell you that all of our instructors are super top notch. And you will get more help than you need. And these restore workshops are amazing. You will fire hose everything NuSmile makes. So I would highly suggest that you take one of these.
And then if you click this QR code, this will take you to the NuSmile, a page on the NuSmile website. And it's got links to every single one of these webinars that goes on, gets recorded and is on there. If you just incessantly love me and Josh, you can watch all of them. However, the questions, the reason we hold the questions till the end is you can fast forward through the webinars and just listen to the questions and answers and learn a ton that way. So again, just a QR code that can help you learn some more along the way. Speaking of help, all these people right here, great humans that are here to help you, all accessible via email and cell phone. Jordan and Aaron are on the call tonight. Isabella is a great sales rep. She'll gladly take your credit card if you call or email her. And then these are additional resources. Preston, Eric, and Nicole, all top tier people at NuSmile that want to help you be successful with devices and materials. And again, we just want to thank you guys so much for hanging in there. It's 9:45. We gave you a lot of information tonight. Now I think you may have some questions to pepper.
And we covered all of the questions except for the very last one, I believe. And I can handle that one. So Jessica asked, so what about older kids over 13? Are we not able to use a SOAN for those kids? No, absolutely not. So let me clarify. What I was saying is that my general rule is 13 and under. I'm pretty sure I can get manual bone penetration. For above that, it's not always 100%, and it's a little bit more less predictable to push through the bone the older the patient is. However, I don't use a traditional syringe in my office, and I've got kids that are 20. So what do? Put it on PDL mode and just give an infiltration with it. The secret there is the needle and the electronic delivery, because what these units do have a ramp up. So it'll initially give a slower bolus of local and allow you to get that initial soft tissue numb, and then it speeds up even faster when it's on PDL mode. So no, you can use this for someone who's 102 if you want. Maybe at 102 they have osteoporosis and it's easier to pop through the bone, but it just has to do with how much, what is your success rate of pushing through the bone. There is another device that Dental High Tech makes, that we use for, adult patients. Now it's also 3.5 times the price, and most pediatric dentists, may not need that in their office, but you can use these on any age. I have big football player kids that are in their 20s, and if I can't get manual bone penetration, I'll just give a PDL with it or infiltration. And what's your experience with ages? I mean, do you find that even with older teens, if you work at it, usually you get through. The question is, just how much pushing you're going to do, correct?
Yes, we usually get through. Jess, you asked the question. So we see 2 to 3 columns. We have 2 doctors every day or 3 doctors every day, and we each see an op every 30 minutes till 1 o'clock. So usually.
And yes, they are that busy.
Yes. So 3 doctors seeing 10 ops every morning. So 30 ops a day, pretty much. We don't do op in the afternoon, and we don't have traditional syringes. So I expect every doctor to figure it out. And I feel like we're a really good petri dish, because if there were problems, I'd be getting pushback. I'd be getting my associates coming to me saying, I can't do it. It's not working. They're not numb. Parents pissed off. Kids not numb, crying, whatever it is. And to Josh's point, sometimes if you can't give the intraosseous, then you just go to a traditional infiltration or a block if you felt like you needed it, but you're not pulling out the traditional syringe. You can still use these devices for that. But I don't know. We don't graduate patients on our practice till age 19, and I'm not getting any blowback. I'm not getting doctors coming to me saying this isn't working. Now, the company's not going to stand behind that. They're going to, confidently tell you to use it to the age. I think the CFU is like 12, 13 is what they'll confidently tell you to use it for. But I don't know. You can push that limit. And the other way you can push the limit, too, is when you do get through the bone, give more anesthetic. The bigger the patient, the more, that's how we're trained anyways, right? You can give less anesthetic to a younger patient than you can an older patient and get by.
IFU is technically 14, up to 14.
14.
And again, that's because of manual bone penetration. That is not actual delivery of local anesthetic.
Yeah, that's exactly right, Josh.
Right.
Like Josh said, we answered pretty much all the other questions throughout.
We had one quick question, any needle breaking. So if, let's say, a needle broke on you, guess what? I don't care, because that needle is sitting in the bone. You just grab how and you'll pull it out. I would much rather have one of these needles break on me than giving a block and have the pterygoid suck that needle back up and then have to call the oral surgeon or my attorney. So I have zero concerns about it.